This is a 15-minute presentation describing the importance of timing related to obtaining blood cultures and administration of the first dose of the ordered antibiotic in the neonatal intensive care unit at St. Joseph's Women's Hospital. There are several slides with screenshots. Larger versions of these documents are posted on a trifold board in the third floor break room. Vermont Oxford has partnered with the Center of Disease Control and Prevention to focus on antibiotic overuse in hospitals' neonatal intensive care units by incorporating one of the CDC's core elements of hospital antibiotic stewardship program as a guide. Neonatal teams have been challenged to evaluate their use of antibiotics and identify any areas of overuse. Antimicrobial stewardship interventions have been shown to improve patient outcomes, reduce the overall burden of antibiotic resistance, and save healthcare dollars. It's important to understand the rationale for this call to action. If overuse is occurring in the NICU, the consequences extend beyond resources and cost. Neonatal antibiotic exposure is associated with necrotizing enterocolitis, hospital-acquired infections, and mortality, as well as asthma later in life. Additionally, antimicrobial use is associated with antibiotic resistance, such in the case of methicillin-resistant Staph aureus or MRSA. In January of this year, the neonatologist joined a group known as INICQ in response to Vermont Oxford's and the CDC's concern with overuse of antibiotics. INICQ is an internet-based program consisting of core curriculum webinars designed to assist NICUs around the world to evaluate the use of antibiotics in their units. The use of antibiotics is calculated as AUR, or antibiotic utilization rate. AUR is defined as the total number of patient days that infants were exposed to one or more antibacterial or antifungal agents administered intravenously or intramuscularly per 100 patient days, and this is expressed in a percentage. Here at St. Joseph's Women's Hospital NICU, we have a very low AUR as a result of practice changes that were implemented by the neonatology group prior to joining this collaborative. Over the past year, hard stops have been added to the MR related to the number of doses or hours of our empiric antibiotic coverage. The neonatologist group has also become more selective with infants that they are ordering antibiotics. The unit's AUR is monitored monthly, and if there is a rise in the rate, this is discussed at the neonatology meetings. We often see a rise when there's an increased number of surgical infants and infants whose mothers have been diagnosed with chorioamnionitis. While our focus is on antibiotic stewardship, it's always important to monitor any unintended consequences of a QI project, and in this case, morbidity and mortality. This is also discussed at the neonatology meeting and during the live webinars. To date, no NICUs participating in the webinar have reported an increase in morbidity or mortality related to practice changes. Before we move on to addressing timely administration of antibiotics, I would like to review early onset and late onset sepsis. Early onset sepsis is most often attributed to organisms acquired from the mother, prepartum, or during delivery. 85% of these babies will present with symptoms within 24 hours of birth. The neonatologists have established guidelines for treatment of the infant that they suspect of early onset sepsis. These are the infants we work up and treat on admission to the NICU. Late onset sepsis occurs at 4 to 90 days of life and is considered a hospital-acquired infection, or an HAI. Hospital-acquired infections can be linked to the environment, hand hygiene practices, multiple interventions that break the skin, and providing access to these organisms. Devices such as UACs, UVCs, PICCs, chest tubes, ET tubes, and open wounds such as ostomies also allow for pathogens to enter the bloodstream. Late onset sepsis can be seen as necrotizing enterocolitis, or NEC, when bacteria invades the gut. The most common organisms associated with early onset sepsis are group B strep, although that has much improved since we began screening mothers and treating them if they screen positive. E. coli, a gram-negative organism that is extremely dangerous and a significant cause of morbidity and mortality in the premature infant, is also listed. Listeria is listed here on this slide, but it's not an organism that we see as often as strep and E. coli. The 3 organisms listed on this slide are sensitive to either ampicillin or gentamicin, and in combination, these drugs offer gram-negative and gram-positive coverage. Organisms associated with late-onset sepsis include coag-negative staph, Staph aureus, methicillin-resistant staph. These are all skin-type organisms. These bacteria enter the bloodstream through breaks in the skin, such as multiple PIV attempts and skin breakdown that we often see in our very low birth weight and low birth weight infants. So remember, the premature infant does not have the skin cornification of a term infant, and organisms can easily permeate their thin, transparent layer of skin. Klebsiella, Pseudomonas, and Serratia are bacteria that are most often associated with water. These are often responsible for ventilator-associated pneumonias, or VAPS. E. coli is usually related to a gastrointestinal organism, and we see this sometimes with necrotizing enterocolitis. We don't see very much Candida in our unit, but we do use fluconazole in infants less than 750 grams. Until recently, we were using it in infants less than 1,000 grams as a prophylaxis agent against yeast. Since our AUR rate, or antibiotic utilization rate, is acceptable, the team at St. Joseph's involved in this NICU Quality Improvement Series decided to review an area related to antibiotics that we could possibly show improvement. We know that in the adult population, timely administration of antibiotics is related to improved outcomes. Data on the relationship to outcomes in the neonatal population is limited, but it is emerging, as neonatal infections are a major healthcare concern and significantly contribute to morbidity and mortality. So, back to our quality initiative to administer antibiotics within an established time frame. Along with the recommendation from ARC, guidelines were developed in 2008 by the Society of Critical Care Medicine, and these are the same as ARC. Their guideline is to administer the first dose of an antibiotic within 1 hour of the decision to treat for sepsis. And the rationale for establishing this guideline is the link that we know exists between timing and risk. These guidelines state that there is an 8 to 9% increase in risk for each hour of delay in treatment. With all this information, it was important for us to look at how well our unit performs in administering antibiotics within an hour. Because treatment often hinges on obtaining a blood culture, that was the first place for our team to begin performing retrospective chart reviews. As you can see, we obtained the blood culture within 1 hour, 69% of the time, and the first antibiotic is started 78% of the time. This information led our INICQ team to ask 3 questions. First, what should we set a goal for obtaining cultures and administering the first dose of antibiotics that is reasonable and achievable? Second, what are the barriers that currently exist in achieving this goal? And third, what new processes need to be put in place so this goal is attainable without adding stress to the team? After learning from other NICUs that have already worked on this project, reviewing guidelines from healthcare organizations, along with the discussions with neonatologists, charge nurses, and team members, our NICU collab at St. Joseph's Women's Hospital decided on this goal. Upon admission to the NICU and among infants with suspected hospital-acquired infections, blood cultures will be obtained within 60 minutes of the written or verbal order, and the first dose of antibiotics will be administered within 60 minutes of the written order with 90% compliance. I want to mention here that our current average time is approximately 70 minutes, so we're already very close to achieving this goal. Delays are related to order entry, line placement, access, and scanning issues. The next several slides address these issues with process improvement strategies. Prior to starting antibiotics, our practice is to obtain a blood culture. The first process improvement addressing blood cultures is a reminder to obtain the blood culture within the 1 hour time frame. This is for all babies, not just our golden hour babies or babies that were less than 1,500 grams or 30 weeks. And this reminder is highlighted on the revised emission data checklist that you see on this slide. You can see the highlighted area with the orange arrow reminding you to obtain the culture within 1 hour of the written or verbal order. If the neonatologist or nurse practitioner is not able to electronically enter the order, you are permitted to take a verbal order. Please document the time that the verbal order was given. The decision to initiate a sepsis workup and treat is considered a critical event, and verbal orders are permitted. The policy and procedure for orders management is posted on the trifold information board in the third floor break room. As soon as the blood culture is obtained, please scan the label in the electronic medical record. It is also necessary to enter the time and date in the EMR shown on this screenshot. This screenshot is also on the back of the new revised admission data checklist as a helpful reminder. It is important to enter this information in the EMR, otherwise the time appears as the time the specimen was received in the lab, and this can be 1 to 2 hours later after you have obtained the culture. So when we were performing chart reviews, it sometimes appeared as if antibiotics were given prior to obtaining the culture. Blood culture collection sets have been created and are located in the admission cart and in the supply room. The bag contains 2 blood culture bottles, 2 alcohol preps, 1 large chloroprep, and a blood culture collection checklist. Please place the completed checklist in the infant's black bedside chart. The neonatologists and nurse practitioners at St. Joseph's Women's Hospital have been notified that you will be calling them if you are unable to obtain the culture. They may elect to give the antibiotic even if you cannot obtain the culture. There are times when an antibiotic is urgent, such as in the case of a baby in shock or rapidly decompensating. In the last INICQ webinar, a pharmacist described a very sad day in their NICU when one of their infants expired. The baby was rapidly deteriorating and all hands were on deck and all supportive measures were offered. Unfortunately, the antibiotics were delayed due to process issues, and while we do not know if this would have changed the outcome, we all want to make sure that every measure was put in place and that we are as effective as possible in our care. This unit has since established the 1-hour goal and improved processes to obtain antibiotic stat when needed. The next 2 slides describe measures to improve the delivery timing of the first antibiotic. Along with a reminder to obtain the blood culture within an hour, the revised admission data checklist has a reminder of the goal to administer the first antibiotic dose started in 1 hour of the order. To assist with this goal, please enter the infant's weight in the EMR as soon as possible. This allows a neonatologist or NNP to provide the pharmacy with a verbal telephone order for a medication. Also, at this time in the physician order set, ampicillin is set as interval timing. If the neonatologist or NNP does not specify a time, it will default to the hospital Q12-hour interval of 9 and 9. The neos and NNPs are aware of this and will be sure to enter a time. Please check your MAR if ampicillin is ordered, making sure it did not default to the Q12-hour hospital schedule. A request for a change in the power plan to correct this has been submitted. You have all been very successful with the Golden Hour initiative to obtain IV access within 1 hour. The majority of chart reviews showed an average of 30 minutes for IV access. If there is a delay due to central line placement, please notify the NEO or NNP. They may elect to hold the attempts at central line access and ask you to start a PIV. As soon as you know antibiotics have been ordered, ask the resource or delivery nurse to obtain the medication, so it will be available as soon as access is obtained, and this will avoid any delays. In the case of early onset sepsis, a lot of the discussion can take place on the way up from the OR and the LDR. The conversation between the RN and the NEO or NNP should include the question, does the plan of care include obtaining a blood culture, CBC, and beginning antibiotics? This information should then be communicated to the admitting nurse and RT. The admitting nurse, delivery resource nurse can work together on the steps of the golden hour with the additional elements of obtaining a blood culture and antibiotic timing. In the situation where the NEO or NNP is waiting to determine the course of treatment until the CBC results are available, it is extremely important you monitor for CBC results and notify the NEO or NNP when they are available. Often the decision to treat is based on the first CBC, so prompt reporting is critical. Please include any pending labs in bedside shift-to-shift report. Remember, the 1 hour begins when the order is written. It's not from the time of birth. And the population that we are discussing is all infants admitted to the NICU. This includes infants that come from downstairs after bonding with their mom for a couple of hours, transports in, or any babies that we work up after their first few days of life. Again, this is a reminder to look for your CBC results. If you look at the bottom of this screenshot, there is a tab that you can click on that will open normal values for you. The steps for sepsis workup in the case of late onset sepsis are the same as the steps for early onset sepsis without all the admission steps. Again, check the MAR for antibiotic orders and communicate with pharmacy regarding any delays. Bedside nurses and respiratory therapists are often the first to pick up subtle changes in the infant. If you have any concerns, please communicate them to the NEO, NNP, or charge nurse. This slide lists some of the signs and symptoms of a baby getting sick. The sooner we identify a status change, the sooner we can begin the workup. As many of you know, the premature infant can go from stable to unstable in a couple of hours. A trifold poster is located in the third floor break room with information contained in this presentation, including the revised admission data sheet, blood culture collection form, and screenshots. For those of you who would like more information, 2 journal articles are attached to the poster on this topic and will also be emailed to you. I am also working with IT so that all team members can have access to the Vermont-Oxford Learning Management System. This site offers 15-minute microlessons related to antibiotic stewardship and other hot topics in the NICU. CEUs can be obtained upon completion of these modules, and there is no cost for the CEUs. The baseline data of 69% and 78% current compliance will be on the Stats and News board, and our improvement numbers will be posted monthly. If you have any questions, please contact me, Jane Solomon, at my Baycare email address. I welcome any feedback and suggestions. I am confident this team can achieve our goal of 90% compliance over the next 2 months. Thank you for the excellent care that you provide to our babies every day. After listening to such a very clinical and dry presentation, I thought my team members might enjoy hearing some of the bloopers. There's one right there. Antimicrobial stewardship, few hours of life, and the substance. Again, this again. No. Here's another slide with showing you a screenshot of no. Start over. Is related to improved outcomes. Incorporate this in slide 7. If the neonatologist or nurse practitioner incorporating one of the CDC's core elements of hospital antibiotic stewardship